Welcome back to the deep dive. In our line of work, we usually associate danger with noise,
Yeah, that's very true.
like the screech of tires before a car crash or the blaring code blue alarm down a hospital corridor, shouting in a trauma bay. Chaos usually has a volume, right?
It usually does, yeah. And human beings are literally wired to respond to loud noises. It is a very basic survival instinct.
But looking at the stack of research for today's deep dive, uh, it seems like the most dangerous moment in an abdominal surgeon's life, and definitely in a patient's life, is actually, well, it's silent.
Dead silent. And honestly, that is exactly what makes it terrifying.
We are stepping into the hospital ward today. Specifically, we're looking at the post-operative period. The surgery's done, the high fives in the OR are finished.
Right, the surgeon has gone out to the waiting room, told the family everything went great.
Exactly. Everyone thinks the battle is won. But we're talking about a specific catastrophic failure that happens while everyone is, looking the other way. The small bowel anastomotic leak.
This is the nightmare scenario. I mean, you have done the work, you've stitched the bowel back together, and then 3 or 4 days later,
The seal breaks.
the seal breaks, and the floor falls out from under you.
And looking at these guidelines and the case reviews you've brought in from the World Journal of Emergency Surgery and all these clinical decision algorithms, this is not just a complication. This isn't just a wound infection that needs some antibiotics. This is a physiological bomb.
It really is. And the reason we need to do a deep dive on this, the reason we are spending this time with you today, is that it's a master class in deception. A small bowel leak doesn't announce itself with fireworks until it is way too late. It is a game of absolute subtlety.
I really like that framing. I want to use that today. This is a strategy game. The opponent is time. The battlefield is the human abdomen. And the stakes, well, the sources are pretty grim on this. If you miss the diagnosis, the patient goes from doing okay to septic shock in, 12 hours?
Easily. Sometimes even less. 12 to 24 hours is your window. That is basically one nursing shift. You come in, the patient looks fine, you go home, get some sleep, come back the next morning, and they are in the ICU on 3 pressors with their kidneys failing. It really happens that fast.
So our mission today is to slow that clock down. We're going to treat this deep dive like a hybrid grand rounds.
Yeah, that's a good way to look at it.
We want to give you, the listener, whether you're a resident, a seasoned attending, or just someone obsessed with high-stakes decision-making, we want to give you the tools to win this game.
We're going to teach you how to see the invisible. We really need to move past the textbook definitions here because, frankly, the textbooks are often wrong, or at least they're outdated about how this actually presents in real life. We need to build the intuition of a master surgeon.
Seeing the invisible, I love that. Let's start with the reality on the ground. To do that, we need a patient. We need to activate our clinical thinking right from the jump.
Okay, let's construct a scenario based on the composite data in these papers. We have a 48-year-old male. Let's just call him Mr. Reynolds.
Okay, Mr. Reynolds. Young guy. 48 is nothing in surgical years.
Exactly. He is arguably in the prime of his life. No major comorbidities, maybe a little hypertension, but nothing crazy. He came in 4 days ago with a strangulated ileal obstruction.
Let's unpack that just a bit for the non-surgeons listening. Strangulated ileal obstruction.
So a piece of his small intestine, specifically the ileum, got twisted or stuck, maybe in an old scar from an appendectomy years ago or maybe a hernia. Because it was stuck, the blood supply was choked off. That is the strangulation part. It is an absolute emergency.
Right, so you took him to the OR, you cut out the dead piece of bowel, which is the resection, and you sewed the 2 healthy ends back together, a primary anastomosis.
Standard procedure. If the healthy ends look nice and pink and they bleed well, you sew them up. You expect him to walk out of the hospital in about 5 days.
So fast forward. It is now post-op day 4, POD4. This is the danger zone, right?
Classic timing. Day 3 to day 5 is when the honeymoon phase ends. The initial adrenaline of the surgery is worn off. The body is trying to rebuild, but the healing hasn't fully solidified yet. That collagen matrix isn't strong yet.
Okay, so you're doing your morning rounds. You walk into Mr. Reynolds' room. He is awake. He's chatting with the nurse. He says, "Doc, I feel a little washed out. Maybe a bit of a bellyache, but I'm okay."
Washed out. God, I hate that phrase.
Why?
It's so vague, it makes you want to dismiss it as normal post-op fatigue. I mean, he just had major surgery. Of course he feels washed out.
It's easy to just nod and move on.
Exactly. It lulls you to sleep.
Well, let's look at the hard data then, the vital signs. This is where the puzzle pieces start to scatter on the table. His temperature is 37.8 Celsius. A low-grade fever, not a massive spike, just, warm.
Right.
His belly is a little distended, maybe slightly more than yesterday. His NG tube, the nasogastric tube draining his stomach, has put out a little bit more fluid overnight,
Yeah.
say an extra 200 cc's.
Mildly concerning. But again, not screaming disaster yet. You could very easily argue that is just a slow recovery curve.
And here's the kicker. You look at the surgical drain, the plastic tube coming right out of his abdomen, placed right near where you sewed the bowel together. The fluid in the bag is minimal. It's just a little yellowish, clear fluid, serious output. It looks totally benign.
And that right there is where 90% of people get completely complacent. They look at the drain, they see clean fluid, and they literally exhale. They think, well, the drain is clean, so the repair must be perfectly intact.
But there's one number on the monitor that we haven't mentioned yet. His heart rate. Mr. Reynolds is sitting there chatting, maybe scrolling on his phone, but his heart is ticking over at 112 beats per minute.
Stop. Right there. That is the alarm bell.
112.
Yeah.
Is that really that high? I mean, he's in some pain. He just has his belly cut open. Maybe he's anxious about going back to work.
112 is massive. If you are laying flat in a hospital bed 4 days after surgery and your resting heart rate is 112, you are physiologically running a marathon while lying entirely still. The body is screaming at you.
So here is the critical question that the sources pose and the trap that Mr. Reynolds is setting for us right now. Is this just postoperative ileus? Is his gut just lazy and slow to wake up? Is this just atelectasis, like maybe he just needs to use his incentive spirometer and cough a bit more to clear his lungs? Or is there a hole in his intestine leaking gut contents into his abdominal cavity?
And I will tell you, most junior doctors and even some senior attendings who are just in a rush to get to clinic, they will look at that low fever, the clear drain, and the mild pain, and they will confidently say, it's just an ileus. Give him some IV fluids, keep him NPO, nothing by mouth, and we'll check on him tonight.
And if you do that,
If you do that, you might have just signed his death warrant. Because while you wait for tonight, that leak is pouring active digestive enzymes directly into his peritoneal cavity.
that is a genuinely chilling thought. We're going to leave Mr. Reynolds there for a second, sitting in bed, heart rate at 112, drain looking deceptively clean, and we are going to back up. Because we need to understand what exactly we're so afraid of. Let's move to section 1, defining the enemy.
We definitely need to understand the beast before we can hunt it.
Let's get into the biology here.
Yeah.
We hear about anastomotic leaks all the time in surgery, but the sources make a massive distinction between a colorectal leak, so the large bowel, and a small bowel leak. Why is that? Is a leak not just a leak?
Not at all. They are completely different animals. You have to think of them as different species of predators entirely. A colorectal leak down in the large intestine is very often what we call a simmering problem. Yeah. The contents of the colon are solid stool, formed feces. It is absolutely loaded with bacteria, billions of them per gram, but it's thick, it is viscous, it tends to stay right where it spills, and because it stays put, the body's immune system can often wall it off into an abscess. It builds a fibrous capsule around it. It is like a slow-burning fire in a trash can. You usually have time to smell the smoke.
Okay, so the colon is a slow burn. It's contained. What about the small bowel?
The small bowel, especially the distal ileum, where Mr. Reynolds just had his surgery, is like a chemical bomb going off.
Why? What is actually in there that makes it so aggressive compared to the colon?
It is a double whammy of destruction. First, you have the bacterial load. Now, the upper small bowel is relatively clean, but the distal ileum is the transition zone. It's right before the colon, so it is filthy. It has almost as much bacteria as the large bowel. So right away, you get immediate, massive bacterial contamination.
Okay, so lots of bugs, a huge infectious hit. But what is the second factor?
Digestive enzymes.
Right. Because the small bowel is where actual digestion and absorption happens.
Exactly. It is literally a soup of highly active enzymes. Trypsin, amylase, lipase, concentrated bile salts from the liver. These things are designed by millions of years of evolution to completely break down proteins and complex fats. That is their only job in the universe. They are biological solvents.
And when you spill that biological solvent into the peritoneal cavity onto the delicate lining of the abdomen, what do those enzymes do?
They do exactly what they were designed to do. They start trying to digest the patient.
That is horrifying.
It is literally autodigestion. They start breaking down the tissues of the abdominal wall, the shiny capsules of the other organs, the blood vessels. It causes a chemical peritonitis that is incredibly, excruciatingly severe. It physically burns the tissue.
Wow. So it is not just a bacterial infection taking hold over a few days, it's an immediate chemical burn combined with a massive bacterial invasion.
Correct. And this triggers a massive physiological cascade. We call it the SIRS response, systemic inflammatory response syndrome. The body completely panics. Macrophages and immune cells hit that chemical burn and they just dump cytokines, these powerful chemical messengers, straight into the bloodstream. And these cytokines cause all of your peripheral blood vessels to dilate. They widen dramatically.
And basic physics dictates that when the pipes widen, the pressure drops.
Exactly. The vascular tank gets much bigger, so the blood pressure starts to fall. Now, to compensate for that, to keep the brain and the heart alive, the heart has to pump faster to keep the cardiac output up.
And that is the tachycardia.
Bingo. That is exactly why Mr. Reynolds' heart rate is 112. It is not his pain, it is not anxiety about his hospital bill, it is his heart desperately beating faster to keep his blood pressure from crashing because his blood vessels are dilating from the severe chemical burn inside his belly.
That connects the dots perfectly. The heart rate is essentially the speedometer of the internal inflammation.
Yes, that's a great way to phrase it. And the terrifying thing about small bowel leaks compared to colon leaks is the speed of this cascade. Because the small bowel fluid is mostly liquid, it doesn't stay put like solid stool. It runs, it tracks along the gutters of the abdomen, it pools up under the liver, it flows down deep into the pelvis. You go from a localized leak to generalized four-quadrant peritonitis in a matter of hours.
So unlike the colon leak, which might kindly form a nice little abscess we can just drain a week later, the small bowel leak is a wildfire.
It is a wildfire in a dry forest with heavy winds. You cannot afford to wait for the traditional smoke signals. You have to learn to smell the heat.
This brings us perfectly to section 2 of our deep dive, the art of detection. The sources call this early clinical clues, but honestly, reading through it, it sounds a lot more like how to not get tricked by your own brain.
Oh, it's entirely about breaking cognitive traps. Human psychology is the biggest enemy in the room.
The biggest trap, mentioned over and over in the outline, is the post-op ileus trap.
Yeah.
I feel like this is where incredibly smart, well-meaning doctors make fatal decisions. Can you explain why this specific diagnosis is such a massive hurdle?
It is easily the #1 reason for a delayed diagnosis of a leak. Here is the fundamental problem. Ileus, which is where the gut just sort of stops moving and goes to sleep for a bit after the trauma of surgery, is incredibly common. Almost everyone gets a little bit of it. Your belly bloats up, you feel a bit nauseous, you don't pass gas for a day or two. It is expected.
So you see Mr. Reynolds on post-op day 4. His belly is bloated. He hasn't passed any flatus. Your brain desperately wants to say, oh, it's just an ileus, it's normal.
It's a comforting lie we tell ourselves. It explains all of his symptoms perfectly without requiring you to declare a surgical emergency and drag him back to the operating room. It allows the surgeon to feel like everything is still under control.
Confirmation bias at its absolute finest. You see what you want to see.
Precisely. But here is the hard rule from the expert literature, and if you are listening to this right now, commit this to memory. Persistent ileus beyond post-op day 3 is a glaring red flag.
Day 3 is the absolute cutoff line.
Yes, normal ileus should be resolving by day 3, or, and this is an even more crucial clinical pattern, if the gut woke up and then went back to sleep.
What does that look like in practice?
Let's say on day 2, Mr. Reynolds passed some gas. His belly was soft. He felt pretty good. You advanced his diet to clear liquids. But then on day 4, he completely stops passing gas. He feels bloated and tight again. He vomits up his apple juice. That regression is catastrophic.
A recovering gut doesn't just decide to go back to sleep for no reason.
Exactly. It goes back to sleep because it is actively being paralyzed by severe local inflammation. It is being bathed in pus and digestive enzymes. The bowel stops moving because the tissue itself is injured and inflamed.
That is such a vivid picture.
Okay.
Okay, so we know we can't trust the bloating because it perfectly mimics a standard ileus. Let's talk about the drain again. I keep coming back to this drain in the case study. In our scenario with Mr. Reynolds, the drain had minimal serous fluid. If there is a physical hole in the small intestine, why isn't gut content pouring out of that tube?
This is what I refer to as the drain delusion. We put these nice silicone plastic tubes into the belly, and we convince ourselves they are magic pipelines to the absolute truth. They aren't. They are highly fallible.
Why do they fail so often?
Mostly physics and biology. Drains get clogged constantly with fibrin or small blood clots. The fluid is thick, the holes in the tube are small, but more importantly, they get walled off by the omentum.
Ah, the omentum. The policeman of the abdomen.
Right. It's this apron of fatty tissue inside the belly that literally migrates toward inflammation to wrap it up and seal it off. It acts like a biological sealant. It will happily wrap right around your drain and completely isolate it from the rest of the abdomen. Or, very simply, gravity just takes the leaking fluid somewhere else. If the anastomotic leak is on the left side of the pelvis and the tip of your drain has accidentally migrated to the right side, you will see absolutely nothing.
So to summarize, a dirty drain full of bile and stool proves you have a leak, but a clean drain proves nothing.
It proves absolutely nothing. Zero. Never, ever trust a clean drain if the patient looks clinically sick. If you rely on the drain output as your primary diagnostic tool, you will miss the leak every single time until the patient is in shock or the pus is literally pouring out of the surgical wound on the skin.
Okay, so drains are out there, liars, bloating is totally unreliable. We're back to the tachycardia. Sources use this specific phrase, quote, respect the tachycardia. It sounds like a religious mantra.
It really should be tattooed on the forearm of every single surgical resident on day one. We talked about the physiology earlier, the heart compensating for the massive vasodilation of sepsis. But the clinical nuance here, the really tricky part, is about unexplained tachycardia.
Unexplained, meaning ruling out the obvious stuff first.
Exactly. If Mr. Reynolds' heart rate is 112, you have to run a rapid mental checklist at the bedside. Is he in agonizing 10 out of 10 pain? No, he said it was just a mild ache. Is he severely dehydrated? No, he has been on continuous IV fluids for 4 days. Is he actively bleeding internally? Well, his blood pressure is still stable. His hemoglobin hasn't dropped. If you cross all of those logical things off the list and the heart is still racing at 112, it is early sepsis, period. End of discussion.
Even if he has absolutely no fever.
Especially if he has no fever. That is the true expert insight in these papers. Tachycardia always appears before the fever. Tachycardia appears before the white blood cell count spikes on the morning labs. The heart is the single most sensitive real-time sensor in the human body.
It sounds to me like a lot of surgeons are just sitting around waiting for the fever to validate their fears before they take action.
Yes. They feel silly calling an emergent anastomotic leak with a perfectly normal temperature chart. They want the classic full house of symptoms before they commit. But by the time that fever finally spikes to 39 Celsius, or the white blood cells hit 20,000, the bacteria have already multiplied 1 billion-fold. You have entirely lost your early intervention window. The tachycardia is the pre-shock indicator.
Are there any other objective numbers we can look at besides heart rate? The outline mentions CRP.
CRP, C-reactive protein. It is an acute phase protein produced by the liver that rises in the blood when there is systemic inflammation.
But wait, isn't CRP basically always high after you cut someone open? I mean, major surgery is massive inflammation by definition.
It is. It absolutely goes up because of the surgical trauma itself. But here is the critical pattern you have to watch. It should peak around post-op day 2, and then it should steadily start falling. If you get to day 3 or day 4, and the CRP is actively rising again, or if it just stays plateaued at a really high level, that is a leak.
Is there a specific hard number we can anchor to?
The current literature frequently cites a CRP greater than 150 milligrams per liter on post-op day 3 or 4 as highly predictive.
Okay, so that is a hard metric we can actually use. CRP greater than 150 on day 3. So let's combine our clinical clues for Mr. Reynolds right now. He has what looks like an ileus on day 4, which is bad. He has a resting heart rate of 112, which is very bad. He has a CRP that is likely rising. We would definitely draw blood to check that. But he has no fever, and his drain looks like water.
The amateur looks at the lack of fever and the clear drain, writes a quick note, and goes down to the cafeteria for lunch. The master looks at the heart rate of 112 and the delayed ileus, immediately stops what they are doing, and calls the radiologist.
That is a perfect transition to Section 3, the detective work, the imaging strategy. So, we are highly suspicious now. We have respected the tachycardia, but we need actual proof. Do we just rush him straight back to the operating right now, or do we get a scan? This seems to be a major fork in the road in the clinical algorithm.
It is the major fork, and it is a strictly binary choice. It all comes down to evaluating one single physiological concept, hemodynamic stability.
Blood pressure and perfusion.
Correct. Let's paint 2 diverging scenarios for Mr. Reynolds to illustrate this. Scenario A, you walk in and Mr. Reynolds isn't happily chatting. He is confused, maybe lethargic. His blood pressure has tanked to 80/40. His skin is mottled and cold to the touch. His belly is completely rigid like a wooden board.
He's crashing. He's actively going into decompensated septic shock.
Yes. In that specific case, taking him down to the CT scanner is putting him in the tunnel of death.
The tunnel of death. That sounds incredibly dramatic.
It's a phrase we use, and it is entirely accurate. If you put a hemodynamically unstable, crashing patient into a CT scanner, they will very likely code and die right there on the table. You are physically isolated from them. You can't easily access their airway if they lose it. You absolutely cannot do effective chest compressions inside a giant spinning magnetic donut. And every single minute spent getting that scan is a minute he is actively leaking more bowel contents and dropping his pressure further.
So if he is unstable, you bypass imaging entirely.
Absolutely. You run, you do not walk, straight to the operating theater. You do not need a high-resolution picture to tell you he has a catastrophic disaster inside his abdomen. His blood pressure of 80/40 already told you that. You open him up and you figure out the details once you have your hands inside.
Okay, plain and simple, unstable equals cut. But let's look at scenario B. Mr. Reynolds is scenario B today. His heart is racing at 112, but his blood pressure is holding up reasonably well, say 110/70. He's lucid, he's talking to you.
Then you have got yourself a little bit of time. You go get the map. You order a CT of the abdomen and pelvis with IV contrast.
Let me stop you there. Why IV contrast? Why not oral contrast? Wouldn't making him drink the dye show exactly where the hole in the gut is?
That is a great question. We actually used to force people to drink that nasty, chalky gastrographin stuff all the time. But really think about the physiology. He has a severe ileus. His gut is paralyzed. It isn't moving peristaltically. If you make him drink a liter of dye, it is just going to sit in his stomach like a rock. It will never reach the leak point down in the ileum in any reasonable time frame. It just makes him intensely nauseous and creates a massive aspiration risk if he vomits while lying flat in the scanner.
That makes total sense. The dye won't travel if the intestinal conveyor belt is fundamentally broken.
Exactly right. So IV contrast is the gold standard now. We inject the iodine dye directly into the venous system, the blood carries it rapidly to the bowel wall, and we are looking primarily for extravasation.
Extravasation,
Yeah.
which is just a fancy radiologic word for leaking.
Yeah. You want to see the bright white contrast dye contained inside the bowel lumen, and then right at the staple line, oops, there's a bright white puddle of dye sitting outside the bowel in the abdominal cavity. That is the definitive smoking gun. That proves the leak with 100% certainty.
But reading the literature, you don't always see that perfect extravasation, do you?
No, you don't, and that's frustrating. If it is a tiny pinhole leak, or if the leak is sort of intermittent depending on the pressure, you won't necessarily capture a dynamic gush of dye at the exact second the scanner takes the picture. So you have to be trained to look for the secondary, more subtle signs.
Like what? What are we looking for on the screen?
Fat stranding is a big one. The mesenteric fat surrounding the bowel should look dark, clean, and black on a CT scan. If it looks hazy, gray, and misty, it means it is highly inflamed. It means something caustic is irritating it. Then you look for localized collections. Is there an abnormal pocket of fluid sitting right next to your suture line that wasn't there yesterday? And finally, you look for free air.
Now, the sources had a really interesting nuance about free air that caught my attention. I was always taught that free air in the belly on any X-ray or CT meant a perforated bowel, and you go to surgery immediately.
In a guy walking off the street into the ER who hasn't had recent surgery, yes, absolutely.
Yeah.
If you walk in with free air, you have a perforated gastric ulcer or burst diverticulum, and you need an operation tonight. But remember, Mr. Reynolds had open surgery just 4 days ago. We physically opened his abdominal cavity. Ambient room air got in. The abdomen isn't a magical vacuum. It trapped a lot of that air when we sewed the muscles back together.
So seeing some pockets of free air is entirely normal.
Yes. It's called post-operative pneumoperitoneum. It is completely expected. However, the body naturally absorbs that trapped air into the bloodstream over time. The key clinical question is the trajectory. Is there more air today than there was on post-op day 1? Or is there a truly massive tension-producing amount of air? If the radiologist calls you and says, I see increasing free air compared to the prior scan, that is not trapped room air. That is intestinal gas leaking out of a hole.
It is all about the trend, the delta.
Medicine is always about the trend. A single snapshot in time tells you almost nothing. The movie tells you everything.
Okay, so let's say the CT comes back. The radiologist calls you on the phone. They say, hey, doc, I see a 4-centimeter collection of fluid right near the ileal anastomosis, along with some severe fat stranding. I don't see active dye extravasation, but the area looks incredibly messy. Now we have a real diagnosis. We have positively confirmed the enemy. This brings us to section 4. The management algorithm. This is how to actually play the game once the cards are on the table.
And again, this completely splits into two wildly different paths based on that core stability question we talked about earlier.
Let's start with the really scary one first. Scenario 1, hemodynamically unstable. This is the crashing patient we entirely skipped the CT scan on. We rushed him straight to the OR because his blood pressure was 80.
Right. You are scrubbing in at the sink. The anesthesiologist is shouting out dangerously low blood pressures over the drape. You make a midline incision and open the abdomen. It is an absolute disaster zone. There is cloudy, foul-smelling pus, maybe dark green bile everywhere. The bowel itself is massively swollen, fiery red, and covered in thick fibrin.
What is the primary surgical goal here? Are we trying to quickly fix the hole in the bowel?
No. And this is arguably the most critical teaching point of this entire deep dive. If you take one single thing away from this hour, let it be this. In a crashing, septic, unstable patient, your only goal is source control, not anatomical reconstruction.
Can you unpack source control for us a bit more?
Imagine you are on a boat, and the boat is rapidly sinking because there is a giant hole in the hull. Source control is just frantically plugging the hole to stop the water from coming in. Reconstruction is trying to sand and repaint the wooden deck and install custom new cabinets. If you meticulously try to fix the bowel to sew it back together perfectly while the patient is actively dying of septic shock on the table, you are repainting the deck of the Titanic.
So priority number 1 is just to stop the spilling of the poison.
Stop the spilling. Wash out the massive contamination with liters of saline. And get the hell out of the operating room.
The sources outline a very strict do not rule here.
Do not attempt a primary reanastomosis in a gross sepsis environment. Do not try to sew the two ends of the bowel back together right then and there. It is a fatal error.
Why not, though? To a layman, if you just cut out the bad part, take down the leak, and sew it up again nicely, aren't you completely solving the root problem? Why leave them with an open stoma if you have the skills to just fix it?
Because of the physical tissue quality. This is where the underlying biology completely betrays you. The patient is in profound sepsis. The tissues are highly edematous. They are incredibly swollen, boggy, and friable. They feel like wet, dissolving blotting paper in your hands. If you're trying to pass a sharp needle and a surgical thread through that diseased tissue, what do you think happens?
It just tears right through.
It cuts right through it. We explicitly call it the cheese wire effect. Just like pulling a tight wire through a block of soft braid cheese, the stitches simply will not hold any tension. Furthermore, in a state of severe sepsis, the body is actively breaking down existing collagen, which is the structural glue of the body, much faster than it can synthesize new collagen. So even if you manage to sew that swollen bowel together and it looks okay on the table, I guarantee you it will completely fall apart and leak again in 24 hours. And this time, the patient will have absolutely zero physiologic reserve left to survive it.
So no sewing in the mud. What is the actual surgical alternative?
You take down the leaking anastomosis, you staple it off and cut away all the nasty necrotic dead edges, and then you exteriorize the healthy bowel ends. You bring them completely out of the abdominal cavity and through a hole in the skin to create a stoma.
A colostomy bag or an ileostomy bag?
Yes. Often what we call a double-barrel stoma, where both the upstream and downstream ends are brought out side by side. Look, it's not glamorous. The patient is not going to like waking up and finding out they have a bag of stool in their abdomen. The family will usually be quite upset. But it definitively saves their life. You live to fight another day. You can easily go back in and reverse the stoma in 3 to 6 months when the patient is totally healthy, well-nourished, and all the abdominal inflammation has completely subsided.
And what if they are really, really unstable, like literally coding or dying on the table before you can even make a proper stoma?
Then you transition to true damage control surgery. You might not even have the 10 minutes it takes to mature a stoma. You just rapidly staple the bowel ends permanently shut with a titanium stapler. You leave the abdominal cavity entirely open, literally. You do not suture the skin or the fascia closed. You just place a temporary plastic vacuum sheet over the exposed intestines, and you run with the bed to the surgical ICU to warm them up, pump them full of blood products, and fix their severe coagulopathy. You come back to the OR 48 hours later to actually finish the job once they can survive the anesthesia.
That is incredibly intense. That is true. Raw survival surgery.
It really is. It is the ultimate surgical humility. It's acknowledging that the trauma of the surgery itself is simply too much for the patient to handle right in that specific moment.
Okay, let's dial down the adrenaline just a notch. Let's look at scenario 2. Stable with a localized leak. This matches our initial case study, Mr. Reynolds, who was sitting up and chatting.
Right. He was stable enough to safely go to the CT scanner, and the CT showed a contained leak.
Contained meaning. The body successfully walled it off before it could spread.
Yes, exactly. The omentum that we talked about earlier, along with some neighboring loops of small bowel, recognized the danger, stuck firmly together around the hole, and trapped the leaking fluid in a small enclosed pocket. It is essentially an abscess now. It is not freely spreading through the rest of the abdomen.
So do we rush him to the OR to operate on this abscess?
Surprisingly, often the definitive answer is no. Do not rush to cut. If it is truly contained, the patient's own body has actually done the hardest part of the work for you. If you go in there surgically, you have to bluntly rip apart all of those protective adhesions to find the leak. You will inevitably break down the walls of that abscess cavity and accidentally spread that concentrated, highly localized infection into the entire pristine abdominal cavity. You take a contained campfire and you manually turn it into a raging forest fire.
So how do we actually treat it if we are explicitly choosing not to cut?
We utilize our colleagues in interventional radiology, percutaneous drainage. The radiologist uses the live CT scanner or an ultrasound to carefully guide a long needle, and then subsequently a pigtail catheter, which is just a curly plastic drainage tube directly through the skin and straight into the center of that fluid collection. They simply suck all the infected pus out.
That seems so much more civilized and elegant than ripping everything open.
It really is. It is beautifully, minimally invasive. You mechanically drain the pus to achieve local source control, you blast the patient with heavy-duty IV antibiotics, and you monitor them incredibly closely.
That is the ultimate pivot point, right? The close monitoring.
Yes, you absolutely do not just put the drain in, pat yourself on the back, and walk away for the weekend. You watch him like a hawk. If he deteriorates at any point whatsoever, if that heart rate suddenly shoots up to 1 in 30, if his abdominal pain suddenly gets sharp and diffuse, you have to admit immediate defeat on the conservative drainage plan and you go straight to surgery. But surprisingly often, the percutaneous drainage alone is completely sufficient. The hole in the bowel actually heals entirely on its own over a couple of weeks because the surrounding pressure and infection are relieved.
Let's bring this all the way back around to our opening story. Section 5. Returning to the case study, we had Mr. Reynolds, post-op day 4, with a resting heart rate of 112.
Right. We were highly suspicious from the moment we walked in because of that isolated tachycardia. We completely ignored the clean fluid in the surgical drain. We ignored the total lack of a fever. We respected the heart rate above all else. Because his blood pressure was fine, we safely ordered the CT scan.
And the findings on the scan.
The scan clearly showed a localized, contained collection of fluid right near the ileal anastomosis. It was about 4 centimeters in diameter, minimal to no free fluid anywhere else in the belly. So it wasn't a catastrophic, uncontained blowout. It was a small, contained leak.
So, because we were vigilant and caught it early, thanks to zeroing in on that tachycardia, it was still contained.
Exactly. If we had blindly waited another 24 hours to see if he developed a fever, that fragile biological containment wall might have completely burst under the rising pressure.
So what was the final definitive treatment for him?
We sent him to interventional radiology. A CT-guided drainage was successfully performed. A pigtail tube was placed directly into the abscess. We immediately started him on broad-spectrum IV antibiotics, usually something robust like piperacillin, tazobactam, and we aggressively monitored his serial blood lactate levels in the ICU to make sure he wasn't silently getting sicker.
And the final outcome?
He rapidly improved. Within about 12 hours of the IR drain being placed, his resting heart rate dropped from 112 down to a totally normal 88. That drop in heart rate is the absolute clinical sign of victory. The low-grade fever fully resolved by the next morning. The collection dried up completely over the next week. We pulled the drain. He kept his normal bowel continuity. Absolutely no stoma bag was needed. And he walked out of the hospital and went home to his family 10 days later.
That is a massive, incredibly satisfying win. But let's play the alternative reality game for a second. What if the surgical team had simply ignored that heart rate of 112? What if they just said, it's just a bit of post-op pain and some anxiety, give him a bolus of fluids and some morphine?
That is the dark, losing scenario. And unfortunately, it is the exact tragedy we review all the time in our departmental morbidity and mortality conferences. If you just give him fluids and wait 12 more hours, the bacteria continue to multiply exponentially inside that space. The digestive enzymes continue to relentlessly eat away at the surrounding tissue. Eventually, the containment simply fails. The abscess violently bursts open into the free peritoneal cavity.
And then the wildfire starts.
Now he rapidly goes into profound septic shock. Now he is severely hypotensive. Now you no longer have the luxury of a minimally invasive drain. You have to rush him to the operating room. You have to open his entire abdomen from top to bottom. You are forced to give him an open stoma bag. He spends the next 2 or 3 weeks fighting for his life on a ventilator in the ICU. He probably gets ventilator-associated pneumonia. His kidneys take a massive ischemic hit, and he might need temporary dialysis. Or, very realistically, he just dies.
The functional difference between a simple plastic tube drain and a horrific near-death experience in the ICU, or actual death, was a doctor simply noticing and respecting a heart rate of 112.
That is the critical difference between controlled play and emergency chaos. It is the razor-thin line between a manageable complication and an unmitigated catastrophe.
This really powerfully highlights the vital importance of clinical vigilance. Let's move to Section 6. Common mistakes and prevention. We've organically touched on some of these already, but let's formalize the ultimate do not do this list.
Sure. Number 1, ignoring tachycardia. We really cannot say it enough times. If the heart is beating fast while the patient is resting, there is a physiological reason. Do not dismiss it. Find it.
Right.
Number 2, lazily labeling a delayed issue as postoperative ileus. If it is post-op day 4 and the gut isn't working right, assume it is a catastrophic leak until you can definitively prove otherwise. Be paranoid. Paranoia saves lives in surgery.
Number 3.
Number 3, waiting around for a high fever to validate your clinical suspicions. Do not wait. The internal fire is already burning violently before the systemic smoke alarm finally goes off.
And number 4, which we spent a lot of time on.
Number 4, reanastomosing inside a septic, heavily contaminated abdomen. That is a truly fatal error in judgment. Do not sow in the mud. Do not let your surgical ego tell you, I'm good enough, I can fix this right now. You can't. The necrotic tissue simply won't let you.
And the overarching theme of all these mistakes seems to be one simple equation. Delay equals mortality.
Absolutely correct. In small bowel anastomotic leaks, time is tissue and time is life. Every single hour of delay from the onset of tachycardia to definitive intervention increases the overall mortality rate significantly.
Now, obviously, the absolute best way to definitively manage a leak is to just not have one in the first place. Let's talk about primary prevention. How do we avoid creating the leak entirely during the initial surgery? Is it mostly just luck and patient biology?
No, it's really not luck. It is meticulous technique. With perfect, fundamentally sound surgical technique, the leak rate should be incredibly low, generally less than 3%. There are strict, non-negotiable fundamental principles of physically joining two pieces of bowel together.
What are the primary keys to getting it right?
First and foremost, far above anything else, is blood supply. Perfusion. When you cut the bowel to prepare the two ends for the connection, the cut ends absolutely must be pink. They must be actively bleeding bright red blood. If they look even slightly dusky, pale purple or blue, you must cut it further back until you find healthy tissue. You simply cannot sew dead or dying tissue to living tissue and expect it to heal. You desperately need robust arterial blood flow to deliver the oxygen and the raw collagen building blocks required for healing.
How do you practically check that in the OR? Do you just look at it under the lights?
Usually, careful visual inspection by an experienced surgeon is enough. You look at the color of the serosa. You can also lightly nick the cut edge with a scalpel blade. If it immediately bleeds bright arterial red blood, you are in a good spot. If it doesn't bleed at all, or it just oozes dark, sluggish venous blood, you have to cut more bowel away. Now, some advanced high-tech centers use something called ICG fluorescence. They inject a special glowing green dye into the 5E, and they use a special infrared camera system to physically see the active blood flow illuminating the tissue on a screen. But honestly, a sharp, experienced eye is usually enough.
Okay, so blood supply is life. What is the next principle?
No tension. This is pure physical mechanics. You absolutely cannot pull the two ends of the bowel together tight, like stretching a banjo string, and sew them. They have to sit together naturally and comfortably. If there is mechanical tension on the suture line, as soon as the bowel inevitably swells up with post-op edema, it will physically tear the stitches right out of the tissue and pull apart. We literally call it the handshake rule. The two ends of the bowel should reach each other easily, like a comfortable, relaxed handshake between friends, not a strained tug of war.
The handshake rule. That makes perfect intuitive sense.
Third is adequate mobilization. This goes hand in hand with the tension rule. You need to meticulously free up the bowel from its natural fibrous attachments in the retroperitoneum so that it physically reaches the other end easily without pulling. And fourth, you must absolutely avoid distal obstruction.
Distal obstruction, meaning a blockage further down the pipe.
Exactly. You cannot safely sew a pipe together if you know it is blocked downstream. If there is an undetected tumor or a severe tight stricture from Crohn's disease further down the line, the intestinal fluid will hit that blockage, back up, the pressure inside the lumen will build up massively, and it will physically blow out your beautiful new connection like a balloon popping. It is just basic plumbing 101.
What about the endless debate I always see online about staples versus hand-sewn anastomosis? I see surgeons arguing fiercely about this. Is one inherently better for preventing leaks?
Ah, the eternal religious debate of general surgery, honestly. The hard clinical data says they are completely equivalent in terms of leak rates, if they are done correctly. Surgical staples are generally faster and much more mechanically consistent. The device fires the exact same way every single time. Hand sewing heavily relies on the individual surgeon's specific manual skill and experience. If you tie the silk knots too tight, you inadvertently strangle the tissue and cause local ischemia. If you tie them too loose, fluid leaks right between the gaps. But fundamentally, a perfectly crafted hand-sewn anastomosis is just as safe as a stapled one. It is entirely about the craftsman wielding the tool, not the tool itself.
One last prevention point mentioned in the sources, nutrition. Specifically something called hypoalbuminemia.
Right, hypoalbuminemia. Albumin is a major circulating protein in the blood plasma. It is a great marker for overall nutritional status. If a patient is severely chronically malnourished, say their serum albumin level is less than 3.0, their body literally does not have the raw amino acid building blocks available to manufacture the biological glue needed to seal that connection.
So what do you do if you have to operate on someone who is that malnourished?
In those highly depleted patients, you have to be extraordinarily careful. Honestly, sometimes you make the tough call to not even try to join the bowel right then. You might purposefully give them a temporary stoma up front, right off the bat, because you scientifically know they simply will not heal well, and trying an anastomosis is too dangerous.
We are coming into the home stretch here. Let's hit section 7, advanced insights and exam pearls. This is specifically for the senior surgeons, the critical care docs, or the really advanced learners in the audience. There is a fascinating statistical paradox about mortality rates mentioned in the research.
Yes, there is. Statistically, across large databases, small bowel leaks actually have a slightly lower overall mortality rate than colorectal leaks if, and this is a massive if, they are detected early and managed aggressively.
Why is that? Given everything we just said about the chemical bomb and the rapid spread,
It comes down to blood supply again. Because the small bowel is so incredibly well vascularized compared to the distal colon, it fundamentally wants to heal. It can mount a much faster, more robust local immune response to fight the infection, provided you drain the pus. But on the flip side of that coin, small bowel leaks have a dramatically higher risk of causing catastrophic diffuse peritonitis because the contents are highly liquid and spread so fast. So it is kind of a double-edged sword. Easier to heal if you catch it instantly, but it spreads and kills you much faster if you delay.
the text also mentions something called abdominal compartment syndrome. We sort of touched on the edges of this with the tunnel of death scenario. What is the actual internal physics happening there?
You have to think of the human abdomen as a closed, semi-rigid container. In states of severe septic shock, the intestines completely swell up with third-spaced fluid. We call it massive bowel edema. Plus, you have the actual leaked fluid pooling up. Plus, the bowel is paralyzed, so it is filling up with trapped gas. The physical volume inside that closed container goes up rapidly, but the muscular abdominal wall and the skin can only stretch so far before they hit their limit. So the internal pressure begins to rise exponentially. When that intra-abdominal pressure gets too high, usually over 20 millimeters of mercury, it forcefully starts to crush the vital internal organs.
What actually gets crushed first? What fails?
The primary victim is the inferior vena cava, the IVC. That is the massive main vein returning all the blood from the lower half of the body directly back to the right side of the heart. It is a low-pressure vessel with thin walls, so the rising abdominal pressure just squashes it completely flat.
And if blood can't get back to the heart,
Then the heart physically has no blood to pump out to the brain. The cardiac output plummets and the blood pressure violently crashes. Simultaneously, that exact same pressure squashes the delicate renal veins going to the kidneys. The kidneys get totally choked off and they instantly stop making urine. It is an absolute rapid physiological death spiral.
and what is the treatment for that if they're in compartment syndrome?
You have to open the zipper. There is no pill for it. You have to take them to the OR, or sometimes do it right there in the ICU bed, and literally slice the abdomen open to release the trapped pressure. The swollen guts will literally forcefully pop out of the incision because they are under so much intense tension. You do not try to close it. You leave the belly wide open, a true laparostomy, and you cover it with a protective plastic dressing until the systemic swelling finally goes down days later. It is gruesome, it is incredibly difficult to manage, but it is absolutely necessary to save their life.
Okay, let's do a quick fire round of exam pearls before we wrap up. Things to strictly memorize for the surgical boards or for your next ward rotation.
Okay, let's tightly lock these core concepts in. 1. Post-op day, 3 to 5, plus any unexplained tachycardia automatically equals suspect in anastomotic leak.
2.
2. A stable patient gets a targeted drain and an IV contrast CT scan. An unstable patient gets an immediate operation.
3.
3. Never, ever try to re-anastomose bowel in the presence of gross contamination or sepsis. Source control is king. Divert and survive.
And 4.
4. The serum lactate trend predicts severe deterioration far earlier and better than waiting for the blood pressure to drop. If the lactate is steadily rising, you are actively losing the physiological game. Step in.
Excellent. That brings us to our outro. Let's concisely summarize the overall game plan one last time for everyone listening.
All right. 1. Suspect early. Be highly paranoid. Remember that the clean drain is very often a liar. 2. Respect the tachycardia. It is almost always the very first sign of the enemy breaching the gates. 3. Scan if they're stable so you have a roadmap. 4. Operate immediately if they are unstable. Do not let them code and die inside the CT scanner. And 5. Absolutely no heroic, ego-driven reconstructions in the face of sepsis. Prioritize source control. Live to fight another day.
And I want to end this deep dive with a final, slightly provocative thought. We so often think of surgeons, and society views surgeons, as the people who strictly fix things, the heroes who go in and cleanly repair the anatomical damage, tie the perfect knot, and save the day. But listening to all of this data, it really sounds like sometimes the fix, the act of sewing things back together, is actually the exact wrong move.
That is a deeply profound realization, and it's one that takes some surgeons years to truly accept. In trauma and emergency surgery, sometimes the bravest decision, and certainly the hardest one for your ego to swallow, is actively choosing not to definitively fix the bowel immediately. It takes immense internal courage to stand at the operating table, look at a terrible situation, and say, I'm not going to sew this up beautifully. I'm going to intentionally leave this young man with a stoma bag on his abdomen. It feels inherently like a defeat. It feels to your surgical brain like you completely failed to restore his anatomy to normal. But in reality, it is a highly calculated, strategic retreat to save that patient's life.
The ultimate victory isn't achieving the visually perfect suture line. The victory is the patient actually walking out of the front doors of the hospital alive, even if he has to wear a bag for a few months.
Exactly. The patient does not care about your beautifully spaced, perfect surgical stitching if he is dead in the ICU. And the patient's entire life fundamentally relies on the surgeon's ability to admit that a massive complication has occurred. To look at that subtle heart rate of 112 on day 4 and say out loud, I might have a severe leak here. And to do that without any hesitation, defensiveness, or ego.
Ego really is the enemy of the early diagnosis.
Very well said. You have to be deeply humble enough to aggressively look for your own failures before they kill the person trusting you.
So for all of our listeners out there, whether you are physically holding a scalpel tomorrow or you're just navigating really complex, high-stakes decisions in your own professional life, respect the early, subtle warning signs. Do not mentally ignore the hard data just because it is highly inconvenient or ruins your weekend. And always know when it is time to stop playing the hero and start playing for the long game.
Apply this algorithm the next time you see a post-op day 4 patient with a slightly racing heart. It really might just save a life.
Thanks for listening to this deep dive. We will see you next time.
Goodbye.